Hello and welcome. Today, we're diving into what is truly a paradigm shift in how we think about our most complex patients. We're talking about cardiovascular kidney metabolic health, or CKM. This isn't about a new disease, but a new unified way of looking at these deeply interconnected systems that we've always known were linked, but maybe haven't always treated as one cohesive problem.
So what exactly is CKM syndrome? Well, back in 2023, the American Heart Association gave us this fantastic, systems-based definition. Think of it as a destructive feedback loop. You have metabolic risk factors, like type 2 diabetes and obesity, interacting with chronic kidney disease and the cardiovascular system. It's this toxic interplay that drives multi-organ damage and ultimately leads to those poor cardiovascular outcomes we're all fighting to prevent.
So here's how we'll break it all down today. We'll look at the sheer scale of the CKM challenge, then we'll unpack the pathophysiology, the puzzle itself. We'll explore why GLP-1RAs offer such an elegant mechanistic solution, zoom in on the evidence for oral semaglutide, and finally bring it all home to what it means for our daily practice.
Okay, let's first get a handle on the size of the problem, because this isn't some niche academic concept. This is the reality for a huge and growing number of the patients walking into our clinics every single day.
Just look at these global numbers. They are absolutely staggering. Hundreds of millions, even over 1 billion for some of these conditions. But you know, the key takeaway here isn't just the individual numbers. It's the overlap. These conditions are not siloed. A patient with one is at high risk for the others. This interconnectedness is CKM syndrome.
And when we bring this closer to home here in India, the CKM framework becomes even more urgent. I mean, look at these prevalence rates. Almost 40% for dyslipidemia, over 35% for dysglycemia. These aren't just statistics. This is the profile of the patient we see multiple times a day.
On top of that, we have the well-known Indian phenotype, that unique mix of sarcopenic obesity, more fat, less muscle, profound insulin resistance, and central obesity. But here's the most sobering part. T2D and cardiovascular disease hit our patients a full decade, sometimes even 2, earlier than Western populations. This really compresses the timeline for us as clinicians and makes early, aggressive intervention absolutely crucial. So, to treat this effectively, we really have to get under the hood and understand the pathophysiology. The AHA has given us a brilliant, clinically intuitive way to think about this complex interplay.
They've broken it down into 3 stages. It all starts with the initiator. That's our metabolic dysfunction, driven by things like insulin resistance. Then that fire gets doused with gasoline by the amplifier, which is chronic kidney disease. And the final devastating destination is the outcome, clinical cardiovascular disease. It's just a vicious, self-fueling cycle.
And let's spend a moment on the kidney as the amplifier, because this is such a critical concept. CKD isn't just a bystander or a comorbidity here, it's an active accelerator. It independently cranks up the risk for MACE and CV death by fueling inflammation, speeding up vascular calcification, and getting into that damaging crosstalk with the heart. The kidney is really the engine driving this cycle forward.
Okay, so if that's the problem, what's the solution? Well, it's pretty clear we need a therapy that doesn't just poke at one part of the problem. We need something that can intervene across the entire CKM pathway. And this is precisely where the GLP-1 receptor agonists become so compelling.
I mean, just look at how perfectly the mechanism of action here maps onto the CKM framework. GLP-1RAs tackle the initiator head-on by improving insulin sensitivity and, of course, promoting weight loss. They blunt the amplifier through their known nephroprotective actions, and ultimately, they improve the outcome with proven cardioprotection. It's like a key that was designed specifically for this lock. Now, a great theory needs great evidence to back it up. So let's look at the data, starting with the GLP-1RA class as a whole, and then we'll zero in on the evidence for oral semaglutide specifically. First up, the big picture for cardiovascular benefit. This landmark meta-analysis from Sitar and colleagues, covering over 60,000 patients, showed a very solid 14% relative risk reduction in 3-point MACE. This really lays the foundation for CV benefit across the entire class. And what about tackling the amplifier, the kidney? Well, that same massive meta-analysis confirmed a 21% reduction in the composite kidney outcome. This is so important. It tells us this class is delivering active cardiorenal protection, not just better glucose numbers.
All right, now let's get specific with oral semaglutide. The Pioneer-2 trial put it head-to-head against a strong competitor, the SGLT2 inhibitor empagliflozin. And what you can see is that oral semaglutide delivered a statistically superior drop in HbA1c, all while achieving very comparable weight loss at the 1-year mark.
Then we have Pioneer-3, which compared it to the DPP-4 inhibitor sitagliptin. The difference here is even more striking. Over 78 weeks, you see superior A1C control, for sure. But look at the weight. More than triple the weight loss with oral semaglutide. For our CKM patients, that's a huge clinical benefit.
Now for the all-important cardiovascular outcomes. Pioneer-6 was the CV safety trial for oral semaglutide. It met its primary endpoint, showing it was non-inferior to placebo for MACE, with a point estimate suggesting a 21% risk reduction, right in the same ballpark as its injectable cousin in SUSTAIN-6. But here's the finding that got everyone talking: a 51% reduction in cardiovascular death. Now let's be clear, this was a safety trial, not powered for superiority, so it's a very powerful signal, but we're all keenly awaiting the SOUL trial to give us that definitive efficacy data.
So, we've seen the framework, we've seen the evidence. Now for the most important part. How do we take all of this and apply it to our clinical decision-making for the CKM patients we see every day? When we're choosing a therapy for a CKM patient, we're really juggling three main goals, right? We need powerful glucose lowering, we need meaningful weight loss, and we need proven CV risk reduction. And when you lay it out like this, you can see that GLP-1RAs really check all three boxes with high efficacy, positioning them as a truly foundational therapy for this population.
Okay, let's talk brass tacks. Prescribing oral semaglutide isn't quite like prescribing other oral agents. The administration counseling is absolutely critical for it to work. We have to stress to our patients, this must be taken on an empty stomach with just a small amount of water, no more than 120 ml, and then they have to wait at least 30 minutes before any food, any other drink, or any other oral meds. This is non-negotiable for proper absorption and efficacy.
And of course, safety first. If your patient is already on a sulfonylurea or insulin, you'll want to consider a dose reduction to lower the risk of hypoglycemia. Also, set expectations about GI side effects. Nausea is common, especially during titration, but it's usually mild and transient. And as with all GLP-1RAs, we use it with caution in anyone with a history of pancreatitis.
So we're left with this really exciting convergence. A new, powerful framework for understanding CKM disease, and a class of therapy that mechanistically targets all its core components, now available in a single oral tablet. It really forces us to ask the question you see here: how could this truly reshape the standard of care for our patients? Thank you for joining me.